Welcome one and all to today, the only one, a good one. Let's make it a great one. I am your host, Cassius Stallings. Blessed and honored to be here. So glad that you all are joining us and tuning into Aspire. Aspire is a webinar that we host here at Health Visions Midwest once a month, and it is a webinar designed to inform and empower us to live our best lives physically, mentally, financially, and socially. Health Visions Midwest is an organization under the Poor Handmaids of Jesus Christ. And so we are a ministry. And we like to begin our time by respecting the pause and saying a prayer. And if prayer is something that you are not interested or maybe not accustomed to doing, please take this time to just mute us and then join us again in a second. Heavenly Father, we thank you, Lord. We thank you for this time. We thank you for this moment. We ask that you open up our hearts and our ears and our minds to the messages that we're about to receive. Bless us on our journey and continue to guide us. In Jesus' name, we thank you, Lord. Amen. Amen. All righty. Well, again, my name is Cassius Stallings. I serve as the wellness coordinator here at Health Visions Midwest of Fort Wayne. I am truly honored and blessed to be in this role and be discussing these topics today. These topics are no easy topics to talk about. They are very serious, and I am so glad that we have the experts here on the call to discuss them with us. We are talking about infant mortality and maternal mortality. In Allen County, we have extremely high rates and disproportionate rates for Black women and Black babies, Black infants. And so we will hear from Dr. Lauren Dungy-Poitras and Dr. Joanne Mattori today. Please help that I said your names right. I'm listen, I'm telling y'all, I have been thinking about that this entire time, and I gotta be transparent about it. I hope I got y'all and did y'all justice, please. Well, I am excited again to hear from them. And so as we gear into this conversation, I want to make sure that we acknowledge these moments, that we take the time to not only again to continue to respect the pause, but realize that it is literally moments that change the trajectory of someone's life. And so what we'll hear is these, although we are plagued with these different rates and things, that a lot of these could have been changed from a simple moment, a simple moment of someone, listening more, someone advocating more, someone just being heard more. And so we're excited for this moment to hear from these two doctors. And now I would like to turn over the screen to Dr. Oh yeah, let's make sure I had the order right. Dr. Mattori, please. We look forward to hearing from you.
Okay, thank you so much, Cassius. Let me work to share my screen. Okay. Hopefully you're able to see my first screen, my title screen, and slide. Great. So let me go back to start with, because I first want to thank you, Cassius and Aspire and your group, for the opportunity to have this conversation with you. I agree with what you said, that oftentimes it's just a matter of spreading the word. And the more people that we can talk with and get the opinion of and share thoughts with, the better we can make this be for our community, for children, for the community, just worldwide, really. But we start small. And so we're going to start today talking about infant mortality awareness. I want to ask a question. Are you seeing the screen as in the slides that you should? Is it fine? Okay, perfect. So to start with, let's talk about the definition of infant mortality. We know that it describes the death of a baby between birth and the first year of their life. The number of deaths that's reported is typically reported out of 1,000 live births. We know that this is an important um, factor because, to make some adjustments here, I apologize. So it's an important factor to realize the fact that the population's overall health is impacted by the same factors that impact infants and lead to their death. And so whereas, an individual might say, well, I don't have any children, I don't have to worry about this. They are missing the point, because whatever negative impacts there are on children that result in their death, and we're going to talk about some of those today, can also then impact the health of the entire community. It's important to recognize and acknowledge that there are causes and there are contributors. Causes lead directly to the death. Contributors are risk factors that make death more likely to happen. And as you can imagine, for infant mortality, there are many different causes of deaths. So I have a few key points on this slide. In particular, in the United States, provisional infant mortality rate in 2022 was 5.6 infant deaths per 1,000 live births. Of note, this was 3% higher than the rate in 2021, which was 5.44. In Indiana, our infant mortality rate is 6.75 per 1,000 live births in 2021, which was increased from 6.6 in 2020. And you may ask why I have 2021 versus 2022. When I pulled together the information, the most recent information that I could find that has been finalized was for 2021. Among the 10 leading causes of death that have been identified by the CDC, 2 causes have experienced significant increases, namely maternal complications and bacterial sepsis of the newborn. So looking at this slide, even though I realize it's a busy slide with lots of information, I want to draw your attention to the upper portion of the screen that identifies infant mortality rates comparing Indiana to the US, and then the Healthy People's 2020 goal, which has now become 2030. But if you look in the most recent numbers for 2020, for Indiana, the infant mortality rate was 6.6 per 1,000, the US 5.4, the goal was 6. As you can see, we have our work cut out for us. And then in the next box, if you look at infant mortality facts, please draw your attention to the 4th bullet point that speaks to, in Indiana, the non-Hispanic Black infant mortality rate was more than double the non-Hispanic white and Hispanic rates. And so I think everyone on the call would agree to the fact that this is a new information, but it's unfortunate information, and it's information that we have to change. So for purposes of today, then, I will speak to the top 10 leading causes of infant mortality. And as I present the information, I have tried, whenever possible, to include some strategies that maybe could lead to risk reduction potentially, or just to give some ideas of things that we could do differently that can help reduce these numbers and remove some of these causes. So number 1 are congenital malformations. They affect 1 in 33 infants born in the US each year. It's a leading cause of infant deaths, accounting for 20% of all infant deaths. Also known as birth defects, if you look at examples, you'll find recognized defects involving the brain, the spine, such as neural tube defects, spina bifida, fetal alcohol spectrum disorder. The eye, you can find cataracts. Heart results in congenital heart disease, mouth, face, cleft lip and palate, and muscle bone osteogenesis imperfecta, or brittle bones, are all examples of birth defects that we see identified shortly after birth, typically. And then chromosomal findings, oftentimes trisomy. There are many chromosomal diagnoses, but I just listed three in particular, three that you perhaps have heard about. And certainly we hear about Down syndrome, which is trisomy 21. So we know that these malformation birth defects may be the result of genetic, infectious, nutritional, or environmental factors that impact the fetus, but oftentimes it's unidentifiable. To help with risk reduction, potentially, it's recommended that vaccinations, particularly during pregnancy, adequate fortification, supplementation, nutrition, and prenatal care are obtained. The second cause for infant mortality is short gestation and low birth weight. This is typically associated with prematurity and infants who are smaller than expected for their gestational age. We find then preterm delivery being a concern, maternal chronic health conditions leading to prematurity in these smaller infants, and then poor nutrition both pre and during pregnancy. This is just a slide of a little guy who is shortly after birth, obviously requiring significant support just to breathe and just to be in existence. And so for risk reduction in terms of prematurity and low birth weight, prenatal care is paramount for management of maternal health conditions, increased awareness, nutritional needs, and appropriate medical management. We have to then, of course, include in this portion of the discussion the avoidance and use of illicit substances, alcohol, and tobacco products, because we know each of these can result in premature births and smaller than average birth weights, and babies then with subsequent illnesses. The third cause for infant mortality is SIDS, or sudden infant death syndrome, defined as a sudden unexplained death of an infant less than 1 year of age that remains unexplained after a thorough investigation. It's actually one type of infant death under a broader category of sudden unexpected infant death syndrome or death or SUID. This graph helps us to look at the trends for SUID. In particular, the top line is the combined SUID rate, and you can see that there's gradually a decrease in the rate. We saw that back in the 1990s, and then we recognize that that was impacted significantly by SIDS, which is sudden infant death syndrome, or the blue line. So you can see a fall and a decrease in the rate, again, in the 90s, primarily related to the recognition that babies need to sleep safely. The bottom two lines, the gold represents unknown causes, and then unfortunately the green line, which you can see even back in the 2017, was starting to increase, and it relates to accidental suffocation and strangulation in the bed. Another way to look at those categories is depicted on this slide, where you can see sudden infant death in the gold portion of the column, unknown causes in the green, and accidental suffocation and strangulation in bed in the purple. And if you look at the second column, which is labeled for the non-Hispanic Black, you'll see that our babies are twice as likely to die as non-Hispanic whites, 3 times as much as Hispanic, and then Asian and Pacific Islanders. Only the American Indian and Alaskan babies have higher rates than we do. So risk reduction for this area in particular, we want to recognize the importance of avoiding SIDS, preventing SIDS with the Back to Sleep campaign. I'll ask that you walk with me through this slide. There are 9 ways to prevent and reduce the risk of SIDS. Number 1, always making sure babies are sleeping on their back, unless there is a contraindication based on their health condition. Never placing a baby in a waterbed, a sheepskin, a soft bedding material. Removing pillows thick and fluffy blankets and soft toys from the baby's bed. As you can see, this baby is in a crib where it's only the baby. And even though very cute stuffed toys and bumper pads and things are sold, they are not safe for a baby to sleep with. Avoid exposing babies to secondhand smoke, car exhaust, wood smoke, and other air pollutants. Limit the baby's exposure to persons who are ill. Dress babies in light sleepwear. Don't overheat them. Cover the babies then with a thin blanket. Use a firm mattress. And above all, recognize that babies should not share a crib with another infant or with an adult in an adult-sized bed. Next are accidents, in particular, lack of infant car seat safety awareness, falls, drowning, burns, and bathing are situations that we know can result in injury and unfortunately death for our babies. Recognize the importance of approved car seats for every child. In terms of risk reduction, supervision by a responsible caregiver is important to avoid all of these, limit the possibility of all of these accidents. There's the importance of properly installed, federally approved car seats for every car ride. So even that brief ride just to the corner store, every child has to be in an approved car seat. We have learned that there are counterfeit infant car seats that you really have to be on guard for. And they look the part. They cost the part oftentimes. They're expensive, but they are not safe and they are not approved for the babies to be riding in. And then rear-facing car seats until at least age 2 years should be identified and recognized. The next two causes for infant mortality actually relate to obstetric complications, so I will mention them for completeness because they're on the list, but I know that Dr. Dungy-Poitras will address them as a part of her presentation. Number 5 is maternal complications of pregnancy, and we know that that's related to absence of prenatal care and maternal health care issues, both prior, during, and following delivery. And number 6, complications related to the placenta and cord. And I included this sketch just to highlight the intricacies and the relationship between the placenta, the vascular cord, and then the fetus. Number 7 as a cause for infant mortality is bacterial sepsis of the newborn. In particular, risk factors include prematurity, prolonged rupture membranes, maternal fever, infection, and chorioamnionitis, and then maternal infections in general. There's a potential for the impact of infection on the infant to lead to death because it impacts every aspect of a baby's body. So from the skin with infectious rashes, the circulatory system can lead to hypotension, low blood pressure, and cold, clammy skin. The GI tract can then manifest infection with vomiting, diarrhea. Central nervous system, we worry about seizures, coma, tremors, all of this impacting the baby's brain and spinal cord. The respiratory system can then be impacted with respiratory distress in the form of grunting, cyanosis, they turn blue, they work hard to breathe. And then lastly, the hematopoietic system, wherein these babies can have bleeding and jaundice because the liver is not able to function, once again, secondary to infection. Risk reduction then for bacterial sepsis in the newborn includes avoidance of potentially infectious exposure risk. In the hospital, we're able to pretty much control that, but when babies are discharged, we ask that the community, the family recognize that if someone is ill, they should not be with that child. The newborn has a very immature immune system, and so whereas as they age and they build their immune system, they're able to fight off infections. Newborns, the first year of life, they are so vulnerable to that. Number 8, respiratory distress of the newborn, which is frequently secondary to prematurity, usually identified shortly after birth, may be related to infection, image lung development in that premature baby, or complications related to the actual delivery. It's so impactful because of the need for adequate oxygenation for the infant's vital organs. That's crucial for their survival. Of note, premature babies who sometimes will have respiratory distress, unfortunately, can have long-term complications, which once again impact their survival in that first year of life. Once again, our little guy who's requiring significant support for respiratory illness. And so potential risk reduction for respiratory distress of the newborn would be prevention of premature birth whenever appropriate, and then close monitoring of moms during labor before they deliver. Number 9, as a cause, includes diseases of the circulatory system, which is primarily in the form of congenital heart disease. This impacts 1 in every 110 births. It may be non-critical or critical. The concern that we have is that in those cases where it is non-critical, these babies, 97% of them will survive through their first year of life. Unfortunately, for the critical congenital heart disease, infants have a shorter survival, and that's because if they are not identified shortly after birth, there can be catastrophic consequences, and as a result, it's sometimes difficult to save those children. They frequently will have diagnoses that require immediate surgeries in the first 24 hours or first week of their life, and then that impacts their entire first year and beyond. I included, that's the picture of a normal heart, only to stress the complexities of the heart and the fact that in the newborn period, any of these areas, any of these portions of the heart can be impacted and result in congenital heart disease for that infant. Risk in the newborn period, we look at a critical screen so that we try to identify those babies who may have those higher risk for congenital heart disease issues. And then the hope is that adherence to recommended pediatric care follow-up is stressed to families and recognized and appreciated by families. And then finally, the last cause in the top 10 for infant mortality includes neonatal hemorrhage. This may be related to abnormal blood products, components resulting in bleeding or clotting problems. It's frequently related to the fragility of the newborn's vascular system, especially for preemies. The brain, lungs, and intestinal vessels are most vulnerable and susceptible. And we also recognize and know that's the fact that newborns have a vitamin K deficiency. Vitamin K is crucial for clotting and avoiding bleeding in any individual. So this little guy, as you can see, is one that he's actually giving us a smile. You can see a normal brain. He has great tone, and this is our goal, of course, for all of our children. Potential risk reduction, prevention of premature deliveries whenever appropriate, and provision of the vitamin K administration to all newborns because we know that they are deficient and without it will have bleeding issues. So my take-home points for you, the infant mortality rate has increased 3% from 2021 to 2022, which means we have our work cut out for us, right? Moving in the wrong direction. There are ways to work to reduce infant mortality, and this is a listing from the Indiana Department of Health. We need to work to improve overall health for women of childbearing age, promote early and adequate prenatal care, decrease early elective deliveries before 39 weeks, decrease prenatal smoking and substance use, increase breastfeeding duration and exclusivity, support birth spacing and interconception wellness, And finally, promote the ABCs of safe sleep, which requires us to ensure the baby sleeps alone in his or her, on his or her back and in his crib. Thank you.
Thank you. Thank you so much for sharing those statistics. All of it was really informational. One of the things that stuck out right there at that end was that increase from 2001 to 2022, or 2021 to 2022, of 3%. That means that this is why we're having this call. You know, we're
Exactly.
trying to bring awareness again to this topic so that we know what is happening, and so that we can come
Yeah.
around this, because a lot of those top 10 that you mentioned, I heard those moments being said again. You know, if we take the time to place a child on their back in that crib with nothing else, then they have a better chance of survival. If we make sure that they're alone, you know, we don't sleep with the child, then they have a better chance. So if we take that moment for this, you know, mom to get those services, then the baby has a better chance. So
Right.
thank you so
Right.
much for
Yeah.
sharing that.
Yeah. And I always add this comment. Many of us slept with our mom or our dad. And, so you will oftentimes have comments that, well, I did it and, you're fine. You could sleep with but we know now that that's not safe. We used to ride in cars without seatbelts. We've learned what can make a difference. And that's a small ask to make certain that when mom gets tired, she's trying to care for a baby, put the baby into his or her crib. It's just small.
Yeah,
Just do
no,
save a
that's it.
life.
You know better, you do better. Yeah. So when we
Yes.
have that information, we have to apply it. Yeah, take those moments. Yeah, that's it. That's it. Well, thank you
Okay.
so much,
Yes.
again, for
Thank you.
sharing. And again, you know, as we transition now to hear from Dr. Nunji Pointers, you know, we know that there's a bridge there. You know, we know that if the mother is taken care of, then the baby will be taken care of as well. So let's hear. Thank you.
Mhm. Yes.
Okay, I'm going to share my screen. Came a second step that I. Says you are screen sharing. Okay, let's see can you guys see my screen?
Yes.
Okay.
Now, yes.
Came up differently that time. Okay, well, I feel blessed and honored to be here as well. And as everybody has expressed, knowledge is power. And I think the more you know you are, before, during, and after pregnancy, as Dr. Maturi pointed out, it can help just all of us. So I'm going to talk about 5 leading issues facing Black women in maternal health. And those 5 leading issues are social factors that affect our health, regardless of our race, but certainly Black women, that can be more impactful, as I will discuss. Maternal mortality, as Dr. Maturi pointed out, is the death of a mom or a person who has been pregnant within a year after that pregnancy. Infant mortality, as she so eloquently discussed. And then there's discrimination, implicit biases, and just simply being ignored, which unfortunately is often more attributed to Black females than to non-Black females. And there are certainly mental health issues. So the first one are social factors that affect health. There's a number of factors. These are that I thought of and put up here, things such as up here, the community safety, the environment you live in, the environment that you work in, housing, what type of housing do you have, transportation, food stability, government, and political and social issues such as voters' rights or other political issues that we face today, domestic violence, education. There's a number of them. When you look at these down here in pink, however, or red, if you are a person of color, you certainly may be more impacted by hate crimes, microaggressions, police brutality, implicit biases, and racism. A person of color is more impacted by those things, as well as other things in society, any of these social factors can certainly impact women of color more than they do for white women. There is indeed a concept called the weathering concept that says that anything that when you're exposed to multiple stressors throughout your lifetime, it can wear the human body down at the cellular level, affecting the cardiovascular, immune, and metabolic systems. These green areas, this is a chromosome right here. We all have them. We all have typically 23 sets of chromosomes. And at the end of each of those chromosomes are these green areas called telomeres. The weathering concept has shown that these telomeres get shortened and they become changed, related to the amount of stress that we face throughout a lifetime, and that can impact the genetic reading and transcription of these chromosomes and the genetic information there. So to further express that, it's a biological response to stress that results in actual changes in our DNA and disease development. That's what the weathering concept is. And prolonged elevation and circulation of stress hormones, things that happen if a tiger jumps through the wall at you, there are things that respond. Your catecholamines go up, your immune adrenal glands kick in, and cortisol levels rise. And there are things that your body naturally does to stress issues to help you handle that stress. Well, if you're repeatedly exposed to those stressors, it can have an effect on your well-being. Examples of stressors that many people face and many people of color face might be just being followed in a department store when you're trying to shop, or being exposed to the mass trauma of seeing on the media the death of George Floyd, or gun violence based on race, inequitable treatment at work, just wear your hair, microaggressions and implicit biases. I once, somebody asked for an example of a microaggression. I said, well, once I walked into a hospital where I work, and I asked where somebody came up to me and said, very pleasant elderly white woman came up to me and said, do you need any help? I said, the doctor's lounge. Can you tell me where that is? I had on a red suit and I looked professional. And she said, oh, the doctor's lounge is only for doctors. So I'm like, well, thank you very much. I actually didn't say anything. I just looked at her and she looked at me and said, well, are you a doctor? And I said, yes, I am. So those kind of things, those kind of microaggressions that other people might miss are certainly things that can affect people of color. And constantly that exposure results in this weathering effect. Michael Liu was the former head of the Maternal Child and Health Bureau. I love the way that he described the weathering concept. He said that the chronic puts the body into overdrive. It's the same idea as if you keep gunning the engine, that sooner or later, you're simply going to wear out the engine. And as women get older, birth outcomes become worse. We know that as a fact. If that happens in the 40s for white women, might actually starts to happen for African-American women in their 30s. And on average, actually these studies were done a while ago, on average, Black women had a genetic telomere age that was 7 years older than a similar aged white person. And Michael Liu said, the stress of being a Black in society can take a physical toll during pregnancy and childbirth. And the facts seem to bear that out. So maternal mortality is indeed one of the things that is higher for Black women compared to non-Black women. It's defined as a death within 1 year of pregnancy by the CDC. It's important to know, if the organization, they only look at 42 days. But the death of any woman who was pregnant within that next year, and as Dr. Maturi pointed out, sometimes our data lags from the reporting because you have to wait a year before you can define it, and you have to look back, and then it takes a year to gather. So by not uncommonly, our statistics years behind, at the very least, of what we're trying to look at. It's well documented that the Black maternal health or mortality rate is about 3 to 4 times higher in Black women compared to white women. If you are Native American, if you are Hispanic or Pacific Islander, you also have white women. We do a poor job, quite frankly, of even looking at or documenting American Indian and Pacific Islanders, but compared to Hispanic, Asian, white women, Black women here in the United States, Black women in Germany, Black women in Europe, they're all higher rates of maternal mortality. Leading causes of maternal death are cardiovascular disease. That disease may have occurred before pregnancy, it may have occurred during pregnancy, or it may develop within a year after pregnancy. So there are ongoing concerns related just to the fact that you are pregnant that can impact your cardiovascular health. Hemorrhage is another leading cause of maternal death, the bleeding episodes that can occur after pregnancy or as a complication of your pregnancy. Hypertension and preeclampsia. Preeclampsia is a condition that only comes with pregnancy. We don't know exactly what causes it. You have to have a placenta to have a baby necessarily. There's a thing called molar pregnancy, but the placenta is a risk factor for preeclampsia. The more placentas you have, if you have twins or triplets, you're further increased risk of preeclampsia. It can be associated with high blood pressure and stroke, and the only cure for it is delivery. Those rates are higher. And with underlying disease such as diabetes or hypertension, which is more common, or at least has higher risks in Black women, but any disease process that affects the underlying blood vessels can put you at increased risk for preeclampsia. Outside of that, even without condition, we know that Black women are more at risk for preeclampsia than white women, or the complications associated with it. And that has to do with the stress factors and that weathering concept as well. Infection is a concern, as well as I pointed out, any underlying medical condition. Infant mortality that Dr. Maturi talks so beautifully about. I'm not going to go over this, but I am going to point out one thing. She talked about the accidents and unintentional injuries, and she talked about safe sleeping, and she talked about putting your baby in a crib. I will tell you the quality of you, and it is just heartbreaking when you sit and listen to a woman who describes trying to do her best, as Dr. Maturi pointed out. And oh, my parents, they slept with their babies, and it's the baby cries, you don't want to put it down, but then you wake up with a dead baby next to you because you've had with you, and unfortunately for some reason rolled over on the bed or suffocated. It is devastating, and we don't wish that for anybody. I will also tell you the very first many years ago infant mortality review case I heard was of a young boy. He must have been maybe 6 years old, who was going to help who had a newborn, help her take care of the baby because she fell asleep on the couch. So he decided he'd give the baby a bath, and he filled the bathtub with water, and he put his baby sister in there to help his mom. And unfortunately, the baby drowned. So there are things that knowledge is power. The better you know, the better, how Cassius said it, but yeah, knowledge is power, and the better you are, the better you are. I say that all the time. And the more you know, before, during, and after pregnancy, the better off we can all be. This upper area here just reflects a study done by the NPR, Harvard, and the Robb Foundation in 2017, where they looked at and asked people, they did surveys just to ask Black women what were some of the concerns that they had with pregnancy. And they found that problems are amplified by unconscious biases that are embedded in the medical system, affecting the quality of care. They identified 33% of Black women said that they had been discriminated against because of their race when going to a health doctor or clinic. And almost 1 in 4, 21%, said that they actually avoided going to a doctor or seeking health care due to the concerns of racial discrimination. Oftentimes we talk about access to care over there. Well, if we don't make it welcoming, we don't make people feel comfortable about coming here, or they have mistrust or issues, we need to address it from a different avenue, as opposed to saying, we're here, come and see us. Discrimination, marginalization, implicit biases, and being ignored are common themes when we look at some of the issues related to maternal health. In 2022, this is Mark Morial, this gentleman here in the lower right-hand corner. He is president and CEO of the National Urban League. Every year they do an equality index. In 2022, Mark Morial expressed that Black Americans are, quote, frustrated about being discriminated against because of their race, and that Black Americans particularly feel the sting of racism in the healthcare system. That 2022 index revealed that an overwhelming 8 in 10 Black respondents feel that race influences the quality care receives, and that 2 in 5 of the respondents said that the system had discriminated against them personally. This gentleman here is Charles Johnson. He had a beautiful wife by the name of Kira. She died 10 to 12 hours after what was quoted as a botched scheduled C-section. She had a routine elective repeat C-section. Shortly after the C-section, they started to notice blood in her Foley catheter, which was unusual and is not normal. They brought it to the attention of the nursing staff. She was evaluated. And Charles Johnson was told that they were going to get a STAT, meaning immediate CT scan. That did not occur. It went hour after hour after hour. The husband and the family were significant about Kira and what was going on. He stated that he repeatedly tried to have the staff do something. Where's this stat C-section? Stat CT scan. He said she shook in the bed. She looked terrible. They kept pleading for something to be done. At one point, they did give her some blood, but nothing else was done. And some 12 hours, at one point, he says that he was told, your wife just isn't a priority right now. They finally took her back to the OR some 12 hours after her initial surgery. The surgeon who took her back was the same one who did her C-section and said, we'll be back in 15 minutes. I went into the OR, opened her abdomen. She had 3.5 liters of blood in her abdomen. That's more than half your total blood volume. That was outside of her blood vessels, doing her no good as far as sending blood, heart, her lungs, her kidneys, her brain, the important organs. And she died on that OR table. He sued, this was at Cedars-Sinai Hospital. So it was a well-known, well-reputed hospital. He sued that system for racism and the wrongful death of his wife. Case settled out of court a little while later. And now Cedars-Sinai is under investigation for concerns related to racism and the treatment of patients. So marginalization, implicit biases, and being ignored, along with discrimination, certainly can. This gentleman right here is Senator Bill Cassidy from Louisiana. In May of 2022, their state was named the lowest, the worst state related to maternal mortality. I should say Indiana's typically always in the lower 5. It's not like we're much better, but they asked Senator Bill Cassidy, he was asked, why are you at the worst? Why are you so bad? And he said, well, you gotta know that about a third of our population is African-American, and African-Americans have a higher incidence of maternal mortality. So if you correct our population for race, if you simply just ignore all the Black people, basically, we're not as much of an outlier as it would otherwise appear. And then he went on to say, I say that not to minimize the issue, but to focus the issue as to where it would be. I don't know what that means, but for whatever reason, he said, for whatever reason, people of color have a higher incidence of maternal mortality. Again, marginalization, discrimination, implicit biases, or just simply being ignored can affect Black maternal health. This beautiful lady here was Chesley Christ. She had a history of depression. She committed suicide at the age of 30. Mental health is certainly something that's affecting everybody across this country, and it certainly was exacerbated by the pandemic. In 2019 and 2020, rates of suicide for women increased. It's important to recognize that in Black people is often underreported. Certainly the diagnoses of anxiety, depression have similarly increased with the rates of suicide. I can't tell you how many patients, when I take an initial history, and I only see them as a consultant, so I always ask what, and I would say that 60 to 70% identify some type of anti-anxiety or antidepressant medicine that they're on. As people of color, there's some intersectionality and layered factors in that. Nobody's simply a woman. Nobody's simply a Black woman. You're a Black female, at least a newborn, or going to be a mother of a newborn. You may have other factors. You may be a maternal fetal medicine specialist. You may be a neonatologist. You may be the director of Aspire. You may be things that there's more to you than just, oh, I am this gender and this race. There's also the individual personalized trauma. Each of us have experience that is individual to us. But then there's mass trauma, like just watching the media reports of police brutality and hate crimes, so watching over and over again when it happened, the murder of George Floyd. Isolation, such as did occur with the COVID pandemic. All of the intersectionality of those components certainly increased the risk of mood or mental health issues and the potential risk for suicide. Postpartum depression is something that affects a lot of women after they deliver. There's a lot of hormonal changes, but to that, you're tired. Anybody who's had a newborn knows that you're up often. There's fatigue, there's stress, there's sleep deprivation. Those all can contribute to postpartum depression. You may, on top of that, still have to care for your other children, your spouse, your other family members. There's a lot of factors that go into it. Black women often for depression. There may be some cultural and spiritual hesitancy to acknowledging that, yeah, I don't feel so great. I do have some concerns about, how I'm feeling and whether I'm depressed. There's also the marginalization and mistrust of the medical system that is not without merit, that who you decide is important as well. If you decide I'm going to tell somebody about it, and somebody in the medical profession, then the question becomes, well, where do we send you? What do we do? We know that there's limited access to mental and behavioral health resources. And even if we can identify those, we unfortunately know that those sometimes lack cultural competence and sense of warrant some of the issues related to people of color. So those are the many factors. I love that Dr. Motori had some risk reduction concepts. It would take a whole lot of more discussion for me to discuss some risk reduction concept for all these factors, but to know that there are that affect your health and things that maybe you can do, seeing a doctor before you get pregnant, certainly, and maximizing your health care before, during, and after pregnancy is important. Maternal mortality, infant mortality, discrimination, marginalization, implicit biases, being ignored, and mental health relating issues facing Black women in maternal health today. Thank you.
Thank you. Thank you so much. I honestly, was a lot to unpack, and to hear that. I honestly just want to take a moment of silence, honestly, to acknowledge those mothers that have been lost. Thank you. Thank you all for taking that moment. And I also want to acknowledge mothers who go through these, Black mothers and individuals whom are not being heard, to hear a doctor say to somebody that they're just not a priority. It's not okay. In the health system, everyone should be a priority. Everyone should be acknowledged. There shouldn't be this discrepancy. There shouldn't be, and we know that there is. And so, again, this is why we have this conversation. This is why we bring awareness to this, so more of us are included on this conversation. I don't see everyone's face, but I know that there's multiple races on this call, and so knowing that we're in this together, and acknowledging individuals in the room and spaces. So thank you both for presenting. We do have some time still for some questions. And as we get some questions in, I also do want to, I've asked a couple folks to be on the call to kind of share some resources. So we'll get these questions answered, and then we'll ask them if everyone still has some time to stay on to get those resources acknowledged as well. So it looks like one of the questions was asked was, what are some changes to training and practices that are being done to meditate these stats?
I can just say that I'm involved in implicit bias training. That I don't know how I got involved in this, but I will tell you, I'm sure it's because I am a mother of 2 Black females, and I tell people I am committed to addressing these issues because they need to change. My daughters deserve better. Your daughters deserve better. And implicit bias can affect the structural racism that unfortunately affects the outcomes. And so there are efforts like that. There is that thing. It's so many factors: politics, government, housing, transportation. There are so many aspects of where changes need to be made, and voting, and other things. There's lots of avenues to help mediate some change.
I'll just add, as a part of the question, I noticed there was reference to training and practices. And I think it's important to have these conversations with our students, medical students, our residents, our trainees along the way, just to make them aware. Because oftentimes it's thought to be something that doesn't impact me. I'm not, I don't have children, so I'm going to take care of the geriatric patient population as I go through my training. So I don't have to worry about these problems. And yet, talking and having that conversation with resident students and trainees can hopefully open up the conversation with their family. And so they may have a conversation over Thanksgiving dinner about something that they heard about, and they talk in terms of an individual who's at the table who didn't know that alone, on your back in the crib without all of the cute things that they're going to receive as gifts, it's not good. And so just hearing that, spreading the word, I think is crucial. Another conversation that I try to have is at time of discharge around holidays. And of course, when we take a new baby home, everybody wants to see the baby. So everyone wants to come and visit. But we have to have some very frank conversations with our family and friends. As I indicated, babies are very vulnerable. Their immune systems have to get developed. They haven't had all of their shots yet. And so to be exposed to someone who perhaps has a cold, which is actually RSV, which is in the news now, could be devastating for that baby and impact survival for that first year. So I think having the conversation and talking more and more with individuals who perhaps aren't directly impacted, but can hear the message and spread the message will help to change the trajectory, for our children and for the children and the community.
There was another question. It said, what did Dr. Matori mean by spacing and interconception wellness?
I'm going to first just reply, but it's actually on one of those, it was one of the causes that's under the maternal side. And so Dr. Dungeon-Poitras will speak to it much better than I, but the birth spacing is important, and then interconception. So being healthy before you get pregnant, but I'll leave it to Dr. Dungeon-Poitras.
Yeah, the March of Dimes suggests that you should wait 18 months between pregnancies to get pregnant again. The risk of premature delivery is higher when you have that short interval. And all the prematurity complications that Dr. Matori discussed. And so you want to give your body some time to recover and, time to, in my mind, to enjoy the current and take good care of everybody in the family before you get pregnant again. But certainly there are higher rates of prematurity and preterm delivery when there's shorter interval pregnancies. 18 months is what is recommended.
All right, we have another comment in here. It says, I personally would benefit from examples of healthcare discrimination. I am thinking that the examples would help many healthcare professionals see what they do in a different light that is interpreted in a negative way. I am thinking the differences in cultures, upbringing, lifestyles play a huge role. If we don't know we're offending another, it will never change. Examples seem to have big impact on learning, at least for me.
Well, as I said, I give a lot of lectures on implicit bias, and some of them include examples. So some examples I can think of, one that's very prominent for me and Black women is sickle cell anemia. In pregnancy, with sickle cell anemia, you're more likely to have a crisis because of pregnancy in the body, particularly in the cold weather, in the colder climates. And so when you have a sickle cell crisis, in a pregnant woman, you need to hydrate them and you need to give them pain medications to stop that process of increased oxygen demand, because I'm in pain. And so, I have increased pain, and you give narcotics for that, or pain management. And I have had, when I give lectures, women tell me when they were pregnant, when they weren't pregnant, where they present to an emergency room for evaluation with sickle cell anemia, that they are denied management. I've in situations outside of sickle cell anemia as well. It's notorious, it's well documented that in emergency rooms that people of color are given less medical management of their pain than white persons. And that when they do implicit testing and include that in the evaluations, there seems to be a bias towards not giving Black people, whether they think historically, the studies were done, a lot of the gynecologic surgery was done on Black slaves, Black women, and without anesthesia. The thought process at the time is that Black people don't feel pain. That's why we can treat them like they're slaves, and treat them like they're cattle. And that makes us feel okay about it, because we don't think of them as having human feelings and having pain. And so that, unfortunately, has carried on. And you can, even in recent studies, when do they think there's differences between Blacks and whites with pain, that sometimes comes up. I don't know if that answered the question, but those are some examples.
I believe.
I can give you another example. So in Columbus, Georgia, there's and I don't know if this is still going on, but I use it in my lecture because it was in the news, and I have the picture. And there was a sign on the waiting room of this OB-GYN office that if you wore a bonnet, you would not receive care. And I tell people, I wear a bonnet on my hair when I go to sleep. I don't like the look of it when I'm going out. I don't like to wear it, but I'm not going to deny somebody care just because they wore a bonnet into my office for their OB-GYN evaluation, particularly if they're pregnant. So those are the kind of things that might seem like they're targeted at a certain population to just, you got to do what I say and look like I want you to look and act, or I'm not gonna be bothered with you.
Yes, that I think that's a great example, especially when we think about the cultural differences, because I think a bonnet is primarily associated with Black culture. I don't see too many others wearing bonnets. So thank you so much for those examples. I wanna take this time again because I know we're a little behind, but I want to acknowledge we asked a couple people to get on the call to kind of share some services so that people know where to go and how we can journey along. So I'm asking Carlos now if you can hop on and share what's going on in neighborhood health.
Yeah, sorry. Can everybody hear me?
Yes.
So I just want to say I appreciate the two doctors that come on this call and started with the education because I think that's one of the most important things is education. And a lot of what we do, we want to localize a lot of this. A lot of what we do is provide access and educations to the patients in our area. One of the most important things is building that relationship with the provider. In our neighborhood health, we have providers for services in medical, dental, behavioral health, optometry, and WIC. We're the local headquarters for WIC. So we have two pediatricians with 30 years of experience. We have OBGYN who has a lot of years of delivering babies, and we have another physician who also has a lot of experience with women. So we have trusted physicians in here that can help you throughout the whole process of your pregnancy and after the fact. And we also have social services women who help women with some of the things that they talked about with sleep education and what you want to do with your child shortly after the birth. So a lot of that things we already have in place. We have people in place to educate you and take you along the way. And we believe a lot of it is about that relationship. Some of these implicit biases come from when you don't have necessarily the right relationship with your provider and you don't have a trust. So we believe give us the opportunity to build that relationship along the way, and healthier mothers have a tendency to deliver healthier babies. So that's what we want to foster here. And we address some of the social determinants of health with pointing people into the right resources when there is an instance when we can't necessarily help you best. So long story short, just come to neighborhood health, reach out to one of our providers, and we'll assist you along the way. And a lot of our people in our department build relationships with long after they have their babies. They come back to us because of those relationships, and they appreciate our willingness to help. So that's all I wanted to say is just, come to neighborhood health, and thank you for the doctors for all the education they provided. I learned a lot.
Thank you. Thank you so much, Carlos. And I've also asked Julie. Julie, if you want to share with us a bit about Associated Churches and Journey Besides Mothers. Julie is still there? She may not be there. So Journey Besides Mothers is an organization that again is Journey Besides Mothers. So those mothers, oh, there she is.
I'm
Okay.
sorry. Yeah, I'm so sorry. I didn't know I had the power to unmute myself. But yes, thank you so much, Doctors Matori and Dungy Poitras. That was so informational. And so Journey Beside Mothers is a ministry of Associated Churches. We are very much relationship based. We connect mothers who don't have a good support system with mentors. We do have a lot of Black mothers, brown mothers, just we're pretty much all of our mothers that we work with are Medicaid eligible. So anyway, but we have a mentoring program where we train women in the community to come alongside moms who need that extra support from. We encourage mothers through advocating with them and for them when needed. We also encourage relationships with mothers together through different we have a play group that meets weekly where we get mothers together with their children so they build relationships and can support each other. We also have a couple other groups that are geared toward like young teen moms to the early 20s that allows us to be able to just teach them things like safe sleep. And we've been doing some oral health education, mental health. We have a therapist who we've just started to be able to work with moms who would like that service, and that has just kind of taken off. And we're so excited about being able to provide that service to moms. So those are the kinds of things that we're doing to support the women that we work with. And it's just been a huge blessing for both those of us who are helping and for those who are receiving the help from our programming. So thank you for having me.
Oh, yes. Thank you. Thank you so much for sharing that. A couple other organizations that I want to highlight as we end our time is Healthier Moms and Babies. They do a lot, again, with moms and babies, coming alongside them in that journey. And then Mission Motherhood is an excellent resource. They actually have gathered all of or several of the agencies that work with mothers and infants. So missionmotherhood.org is a phenomenal website to check out to get some of that information and know where to go as you navigate motherhood and early child raising. So that is our time. I am so thankful everyone who tuned in. Thank you again, Dr. Warren Dungy-Poitras and Dr. Joanne Matoi. So glad to be saying your name, saying it right.
You're good. Yeah.
Thank you for sharing. And I hope that we will continue to raise awareness and come around each other and build more community. Acknowledging ourselves and acknowledging each other just that much more, and continue to take those moments and respect the pause. So thank you so much. Until next time.
Thank you for the opportunity, Cassius.
Indeed. Have a blessed day.
Yes.
Thank you.